It is a sustained elevation of the portal venous pressure, more than 10 millimeters of mercury. The normal portal venous pressure is about 5 to 10 millimeter mercury. Causes of portal hypertension include the pre-sinusoidal, which either extrahepatic or sinusoidal or post-sinusoidal causes. The pre-sinusoidal include the portal splenic vein thrombosis, which account for approximately 50% of cases of portal hypertension in children. The intrahepatic causes include schistosomiasis, sarcoidosis, congenital hepatic fibrosis, and primary biliary cirrhosis. Sinusoidal cirrhosis, hemochromatosis, Wilson disease, non-alcoholic steatohepatitis. The post-sinusoidal include Budd-Chiari syndrome, constructive pericarditis, and veno-occlusive disease. The portal circulation. The liver is unusual in that it has a double blood supply through the right and left hepatic arteries, which carry oxygenated blood to the liver and responsible for about 25% of blood supply. And the portal vein carries venous blood from the GIT tract to the liver. The venous blood from the GIT tract drains into the superior and inferior mesenteric veins. These two veins are then joined by the splenic vein just posterior to the neck of the pancreas to form the portal vein. Then it splits to form the right and left branches, each of which supply about half of the liver. On entering the liver, the blood drains into hepatic sinusoids, where it is screened by specialized macrophage cover cells to remove any pathogens that manage to get past the GIT defense. The portal vein blood contains all of the products of digestion absorbed from the GIT tract. Sites of portosystemic collateralization. First and most important, the lower end of esophagus, which is between the left gastric and short gastric veins with azygous vein, resulting in esophageal varices, which is the commonest. The second one, the umbilicus between paraumbilical vein and anterior abdominal vein, resulting in caput medusae. The lower end of rectum between the superior hemorrhoidal vein and inferior and middle hemorrhoidal vein, resulting in piles. And the retroperitoneal veins of Rhizios, and the last, the bare area of the liver. There are four important effects of portal hypertension. First, development of collateral portosystemic venous drainage. Second, splenomegaly. ascites in hepatic and post-hepatic portal hypertension only, and then the manifestation of hepatic failure in severe cirrhosis. As a result of increased portal venous pressure, the collateral channels developed and shunting of blood, resulting in collateral shunts, like, as we mentioned, esophageal varices, piles, caput medusae, and retroperitoneal splenomegaly. Progressive splenic enlargement occurs as a result of portal congestion, together with some degree of hypertrophy of splenic substance itself. It is often associated with hematological changes of hypersplenism like leukopenia, thrombocytopenia, anemia. The anemia accompanying splenomegaly can be accounted for gastrointestinal bleeding and is not necessarily as a result of splenic enlargement. Ascites. In general, the causes of ascites, liver failure and portal hypertension, which is our subject today, carcinomatosis with ovarian malignancy or any other intra-abdominal malignancies, heart failure, renal failure, chronic peritonitis like tuberculosis, and pancreatitis. The causes of ascites in portal hypertension include hypoproteinemia, increased hydrostatic pressure, decreased colloidal osmotic pressure, lymphatic blockage, and altered aldosterone mechanism. The effects of portal hypertension include, first, the effects of liver failure that include jaundice, ascites, and encephalopathy. To the surgeon, portal hypertension presents as three problems. First, as a differential diagnosis of jaundice or hepatomegaly. Second, as a cause of gastrointestinal hemorrhage, and as one of the causes of ascites. The presentation of portal hypertension. Triad of portal hypertension include esophageal varices, splenomegaly, and ascites. Jaundice, feature of encephalopathy, recurrent infections, coagulopathy, and hepatorenal syndrome. In general, there is weakness, tiredness, anorexia, weight loss, abdominal pain, jaundice, edema, pruritus, spontaneous bleeding and bruises, impotence, muscle cramps, pallor, cyanosis, hypotension. Presence of features of variceal bleeding include anemia, hematemesis, melena, shock. Bleeding may be from gastric and or esophageal varices or portal gastropathy. Features of encephalopathy, Features of liver failure, including gynecomastia, palmarythemia, leukonychia, testicular atrophy, spider angiomas, parotid enlargement, cyanosis, tachypnea, ascites and generalized edema, edema of the scrotum, abdominal wall, and limbs. The ascites is a sign of hepatic decompensation. Decreased urine output, which is a feature of renal failure, the hepatorenal syndrome. Special investigations for portal hypertension. In addition to history and examination, we should do the following investigation. First, the liver function test to assess the degree of jaundice, which is an important prognostic indicator in cirrhosis. Second, the liver synthetic function test, like prothrombin, INR time, and albumin. Liver markers and other markers like alpha-1 antitrypsin, ceruloplasmin, autoantibodies for evaluation for hepatitis B, C, D viruses. Ultrasound can assess the focal liver lesions, portal venous flow, splenomegaly, and presence of intra-abdominal varices. Fiber optic endoscopy, which demonstrate varices, which differentiate between the bleeding from this source and from peptic ulcer or multiple gastric erosions. Contrast abdominal CT or MRI scan. Liver biopsy to determine the cause of cirrhosis as well as clinical deterioration. Acetic tab is useful. And inferior vena cava cavogram, which can demonstrate the hepatic venous occlusion and portal pressure measurement. Management of portal hypertension. First, the general measures. We have to correct anemia, nutritional supplementation, vitamin K is required for 5 days IM injection, 10 milligram of vitamin K. Blood and blood product transfusion also required. Specific measures include treatment of esophageal varices, prevention of hepatic encephalopathy, treatment of ascites, and measures to reduce portal pressures. Surgery by portosystemic shunting. Tips: drugs to reduce the portal pressure like propranolol, nadolol, and isosorbate 5 mononitrate. And the last is the liver transplantation. The patient who presents with upper GIT bleeding can be approached as whether the bleeding is from varices or from other causes. As we mentioned, not all upper GI bleeding in cirrhotic patients are from esophageal or gastric varices. The differential diagnosis of variceal hemorrhage include the following: acute gastric erosions, duodenal ulcer, gastric cancer, Mallory West tear, and nasogastric tube trauma, and portal hypertensive gastropathy. These esophageal varices or gastric varices may be asymptomatic or may be present with hematemesis or melena or recurrent bleeding. The varices begin to bleed when portal pressure exceeds 12 mm mercury. Mortality in bleeding varices is about 25 to 30% of cases. Types of varices from this picture, we can see esophageal varices and gastric varices. Management of hemorrhage from gastroesophageal varices. Hemorrhage from gastroesophageal varices is particularly dangerous, especially in patients with liver damage. In these subjects, the liver is further injured by the hypotension of blood loss and encephalopathy that precipitated by absorption of a large amount of nitrogenous breakdown product from the blood ingested. How we control acute bleeding. We have initial important measures. We have to ensure adequate access by two large bore intravenous lines, fluid infusion, cross match of blood, and blood products should be prepared. Volume and electrolyte correction with adequate replacement using crystalloid, using central venous pressure line, and this pressure should be maintained at about 5 centimeters of water, and we have to avoid sudden overload, which could precipitate pulmonary edema, ascites, and hyponatremia. Blood should be given. We may require a massive transfusion of 5 or more pints of blood. Antibiotics, vitamin K injection, and we should monitor urine output, prevention of encephalopathy with rest and sedation only if needed with care. Pharmacotherapy by using of vasopressin injection in a dose of 0.4 units per minute for 24 hours, which is commonly used. The vasopressin infusion is combined with the glyceryl trinitrate tablets sublingually to reduce the cardiac side effects and to increase the efficacy of vasopressin. The vasopressin is contraindicated in ischemic heart disease as it causes coronary vasoconstriction. The vasopressin effect constricts the splenic vessels, so it lowers the portal pressure and then control the variceal bleed. It controls the bleeding in 80% of cases, and it is often used along with balloon tamponade to increase bleeding control to 95% of cases. Second, the libricine, terlibricine, which is better than vasopressin. It has a longer half-life with fewer side effects. Somatostatin, the half-life about 2 minutes, which does not cause systemic vasoconstriction like vasopressin, but reduces the splenic and hepatic blood flow. It is given as a continuous intravenous infusion after an initial bolus dose. Fourth, the octreotide, which is a synthetic analog of somatostatin with half-life of 2 hours, which is the agent of choice in acute bleed. It decreases portal pressure and azygous blood flow, which stops variceal bleeding in 80% of cases. The efficacy is similar to endoscopic sclerotherapy and better than vasopressin. The side effect of octreotide, it causes mild hyperglycemia and abdominal cramping. Propranolol, that decrease the portal pressure, which is used at a later period as a prophylaxis to prevent bleeding. Nadolol is also used, which has got a longer half-life. Metoclopramide 20 mg IV, it causes lower esophageal sphincter constriction. Proton pump inhibitors also could be used. And tranexamic acid is other drug that also used in variceal bleeding. Endoscopic therapy. Endotherapy by banding, sclerotherapy, gluing is used to control acute bleed as well as to prevent further bleeding. And it is often combined with the pharmacotherapy. The endoscopic banding, which is done for esophageal varices, become a gold standard and ideal for esophageal varices. Using a multi-shoot banding device, which is not commonly done for gastric varices, where banding is difficult in retroflex position. The banded varices thrombose and then slough off, leaving a small discrete ulcers. It controls the bleeding in 90% of cases, which is technically easier. The chance of rebleed are less, but complications like perforation or stricture could occur. Endoscopic variceal sclerotherapy is also commonly used. It is easier, cheaper, by intravaricial or paravaricial or only intravaricial injections are given. When we use both the para and intravaricial injection, first the paravaricial injection is done into the submucosal gland, followed by intravaricial injection. The varices should not be injected blindly. Sclerotherapy causes intimal injury with submucosal vessel thrombosis, ulceration, and then submucosal fibrosis. We need about 5 to 6 sclerotherapies to create total obliteration of the varix. The success rate is about 80% of cases. The complications include local and systemic. The systemic one, fever, retrosternal pain, massive bleed, perforation, mediastinitis, stricture, and atelectasis, pleural effusion, IRDS are known to occur. These are local and systemic complications. The sclerotherapy is done weekly for 6 to 8 sessions until varices are obliterated. Endoscopic gluing using tissue adhesives, which is commonly used for gastric varices, using cyanoacrylate, which is hardens in about 20 minutes and should be used properly because of a risk of damage to our instrument or scopes when it spills into the working channels. Other option by using endoscopic thrombin and diluted adrenal injection into the varices. Other option to control the variceal bleeding by using balloon tamponade. This use in hospitals where there is no access to the endoscopic management, and it is considered as an emergency procedure done to control the bleeding and to refer the patient then to the specialized center to deal with the bleeding. By using Singistakin Blackie-Moore tubes or Minnesota tube, and when a bleeding does not stop, also by banding, sclerotherapy, gluing, balloon tamponade, this should be tried. Most of the time, bleeding comes under control by balloon tamponade. And this should be deflated for a short period in 12 to 24 hours to prevent necrosis of esophageal mucosa. The inflation of gastric balloon is most important with the esophageal balloon inflation is done if needed only. Then the X-ray should be taken to confirm the position of the balloon. Success rate is very good, but as we mentioned, should be done for a short period of time. And then after that should be followed by definite procedures like banding, sclerotherapy again. Otherwise, the rebleeding rate is about 60% in balloon tamponade only. It is a rescue procedure and it is an emergency bridging method for more definite procedures. Ascites. Tips: the transjugular intrahepatic portosystemic shunting. It is used if all other aerial methods mentioned have failed. It commonly controls the uncontrolled acute bleeding and prevent further bleed, and also it acts as a bridge to future transplantation. It is a non-surgical interventional radiological method wherein a stent is placed in the liver between the hepatic venule and portal venule through a guide wire following dilatation. It is a simple and easy method to reduce portal pressure, but it can cause hepatic encephalopathy, bleeding, bile leak, and infection. It is contraindicated in encephalopathy, tumors, and liver cysts. Problems with TIPS include post-stent encephalopathy in 40% of cases, stenosis and recurrent varices, bleeding, bile leak, and sepsis. Other sequelae of portal hypertension should be treated is ascites. The complications of ascites include respiratory embarrassment, umbilical hernia with erosion, ulceration, and leak with spontaneous bacterial peritonitis. The treatment include diet with a low sodium, high protein diet, diuretics, spironolactone, often combined with thiazides or loop diuretic. The paracentesis gives an immediate relief if the discomfort is intense, but it has disadvantages that the patient loses protein and this should be replaced at a time of aspiration by 10 grams of albumin per liter of ascites removed. Also, TIPS shunts and liver transplantation is an indication of intractable ascites due to hepatic cirrhosis, which is performed after the failure of medical therapy. Surgical intervention in portal hypertension by portosystemic shunt, devascularization procedures, and orthotopic liver transplantation, which is the treatment of choice in patients with advanced liver disease. We have to put in our mind that surgery has no role in primary prophylaxis. Its role in acute variceal bleeding is limited because with endoscopic treatment control bleeding in about 90% of patients. The TIPS is a variable option and less invasive for patients whose bleeding is not controlled. We consider surgery for prevention of rebleeding when pharmacological and/or endoscopic therapy have failed. The decompressive shunts. Surgical shunting provide better control of rebleeding when compared to combination of therapy of beta blocker and endoscopic variceal ligation. But these shunts are associated with higher incidence of hepatic encephalopathy and should be reserved for child class A patients with recurrent bleeding despite adequate combination therapy. These shunts include total portal systemic shunting, partial portal systemic shunt, and selective shunt with devascularization procedures. The total portal systemic shunts. These shunts larger than 10 mm in diameter between the portal vein or one of its main tributaries and the inferior vena cava. We have side-to-side portocaval shunt when the portal vein and infrahepatic inferior vena cava are mobilized after dissection and anastomosis is done. All the portal flow is directed through the shunt. This gives an excellent control of bleeding and ascites, which is achieved in more than 90% of cases. But the encephalopathy rate, about 40 to 50% of cases with progressive liver failure are possible. The partial portal systemic shunting, which reduces the size of anastomosis of side-to-side shunt to 8 mm in diameter. The portal pressure is reduced to about 12 mm mercury, and the portal flow is maintained in 80% of patients. The partial portal systemic shunt with operative approach is similar to that for side-to-side portocaval shunt, except the interposition of a graft must be placed between the portal vein and inferior vena cava. We have selective shunting also, which provide selective decompression of gastroesophageal varices to control bleeding, while at the same time maintaining portal hypertension to maintain portal flow to the liver, like in the distal splenorenal shunt, which is the most commonly used decompressive operation for refractory variceal bleeding. The devascularization procedures is rarely performed, but may have a role in patients with portal and splenic vein thrombosis, who are not suitable candidates for shunt procedure and who continue to have variceal bleeding despite endoscopic and pharmacological treatment. These procedures consist of transabdominal devascularization of the lower 5 centimeters of esophagus and upper 2/3 of the stomach. The incidence of liver failure and encephalopathy is low following devascularization procedures because of better maintenance of portal flow. Splenectomy. The spleen is one of major inflow paths to gastroesophageal varices. The splenectomy allows better access to the gastric fundus and distal esophagus to complete the devascularization. The portal vein thrombosis, as much as 20%, is reported following splenectomy. The ascites is a frequent early postoperative complication because the portal hypertension is maintained. Then, liver transplantation. This should be considered for patients with an end-stage liver disease, like in patients with cirrhosis, with child buff score 7, and the selection of the candidate for liver transplantation should be directed to the patient clinical status, etiology of cirrhosis, like viral hepatitis, alcoholic, non-alcoholic, steatohepatitis, cholestatic liver disease. The liver transplantation is considered as an ultimate shunt because it relieves portal hypertension and prevent variceal rebleeding, then managing ascites and encephalopathy by restoring liver function. It is the treatment modality that has significantly improved the outcome of patients with child-Buff class C disease and variceal bleeding. In most patients, it is important to use liver transplantation to treat portal hypertension. It is not practical because these individuals can be managed with successful results with lesser methods. So the use of transplantation must be based on appropriate patients. Thank you.